Now let us take up the next very high yield topic for the entrance, pulse. What is the topic number? Maybe some 15th or 16th topic, right? So let us quickly summarize what are all the questions asked on the pulse in case of the various exams. Water hammer pulse, where do you see, doctor? We see typically a large bounding pulse with an increased stroke volume, with a decreased peripheral vascular resistance, with a wide pulse pressure. In case of aortic regurgitation, we find the presence of the water hammer pulse. Now, what is the importance of the water hammer? Why it is called water hammer? It's called water hammer because water hammer is this water pumping toy. I think you know very well what is it. In aortic regurgitation, what happens? Left ventricle enthusiastically pumps the blood into the root of the aorta, and immediately following that there is a regurgitation. So there is a rise of the pulse, immediately there is a fall like a water hammer. So this is because of a early diastolic runoff and a backward direction regurgitation. It leads to this water hammer quality of the pulse. In the case of the aortic regurgitation is what need to be basically remembered. And in order to, how do you know, how do you check for that quality on pulse examination? You feel the pulse, raise the hand, and it is collapsed. So it is very classical of aortic regurgitation. Then pulsus bispherians, if you want to check it, it is the peripheral arteries, especially radial artery is the best place for you to check, radial and brachial. Can you tell me which pulse is better observed checking the carotid? Anacrotic pulse, somebody has LV dysfunction, he will have anacrotic pulse which is better felt in the carotid, is what you need to fundamentally understand. Then what is pulsus paradoxus? As we have already discussed, there is no paradox about it. What is the normal phenomena? Whenever we have inspiration, there is a negative intrathoracic pressure and there is a increased venous return into the right side of the heart that will press on the left side of the heart. So left sided output will decrease. So that is the reason pulse will diminish when we have inspiration. Suppose if I have asthma or any cardiac tamponade, what will happen? This phenomena become exaggerated. So at the time of inspiration, simply it is not the decrease, this total collapse of the peripheral pulse will happen. And then why it is called paradox? The pulse is not felt but the stethoscope is listening the heart sounds. So that is paradox about it. So the normal inspiratory fall of the peripheral pulse because of a decreased left ventricular output, because of the increased right ventricular output, because of a increased venous return at the time of inspiration is basically exaggerated in the case of pulsus paradoxus, and it is seen in pericardial tamponade, COPD, superior vena cava obstruction, constrictive pericarditis, etc., etc. Then one more question on pulsus bispherians. You need to know that it is felt in the case of the radial artery. And where do you see bispherians pulse? Where in the systole there are two peaks in the pulse called bispherians, is what you see with hypertrophic cardiomyopathy, and also when AS plus AR together are there, and similarly in severe AR also you find a bispherians pulse. Now let us quickly examine what is the contour of each of these pulses, doctor. This is the normal arterial pulse which you can see here, and this is called pulsus alternans. One is strong beat, other is weak beat, other is strong, next is weak beat. Where do you have this? If I have an acute MI with a LV dysfunction, then one beat will be strong, other beat will be low. So pulsus alternans is typically seen with the LV dysfunction in the patients who have an acute MI. Two peaks in the systole, pulsus bispherians. This kind of two peaks is what you see with HOCM. Why in HOCM? Already we discussed. In the HOCM, hypertrophic obstructive cardiomyopathy, there is a hypertrophied interventricular septum, and ventricle at the time of systole initially nicely pumps the blood out, but after some systole is over, this interventricular septum and the mitral valve will come closer to each other, and that will cause a LV outflow obstruction. So the outflow stops. Then once more, that is a dynamic obstruction which relieves in the later part of systole. Once more the ventricle continues to pump. So two peaks will be there in the pulse called the Bispherians pulse of HOCM is what need to be fundamentally understood. Then pulsus paradoxus means at the time of inspiration pulse will decrease in its amplitude, whereas in expiration it will be normal. So this is what you see with the pulsus paradoxus is what I like to underscore to all of you. Now where do you see pulsus paradoxus? What are all the conditions? Cardiac tamponade, hypovolemic shock, pulmonary embolism, pregnancy, extreme obesity, constrictive pericarditis, etc., etc. Then once more, it is the cardiac tamponade where pulsus paradoxus is a feature. Then where do you see pulsus alternans? Even for the PGI entrance also it is a favorite topic of the examiner. You need to remember that in acute MI with LV dysfunction we find the development of pulsus alternans. Then once more pulsus paradoxus, where do you see? We see it in the case of pathology like constrictive pericarditis. Then what do you mean by pulse pressure? We need to know that systolic minus diastolic is the pulse pressure, which is generally around 50 millimeters of mercury. And pulsus Bispherians, where do you find? Once more a repeated question so frequently. So you must know pulsus alternans, paradoxus, Bispherians, little here and there about pulse. One question is definitely sure from the cardiology when it comes to the topic of pulse is what need to be remembered.